I think y'all are in a good mood because you just had lunch. I was actually thinking to myself, is it worse to be the last person before lunch or the first person after lunch? All right. So my name is Dr. Matt Goebel. I'm with the Department of Emergency Medicine. I was going to make a joke about pausing for applause, but you already did, so I'll skip it. I am actually our current EMS fellow, and if you're thinking to yourself, well, I didn't know Bay State had an EMS fellowship, that's because we didn't. I'm the first one. So we'll be talking to you about EMS pre-activation and improving pre-hospital care for STEMI patients. I have no financial conflicts of interest or disclosures. I made this joke last year, but it continues to be true, so I'll make it again. Sometimes Bay State doesn't even pay me. STEMI is the poster child for pre-hospital activation of resources and partnership between EMS and the emergency department and inpatient services for expediting and improving care for any patient population. It's the poster child. We've been doing it here the longest, and we've shown the best, biggest, most improvements. Now, the process has a number of moving parts. First, you've got to have the patient recognize that they're having cardiac symptoms that are concerning. They have to call 911, where the medical dispatching and triaging occurs. The unit has to get dispatched. They have to arrive on scene and do their thing, get them to the hospital. Traditionally, at this point, the EKG would be done to diagnose STEMI. Cath lab gets paged. We wait. And then we get the patient up and get our successful angiography done. Now, the first third of this process is not super readily modifiable. This has to do with the design of the EMS system, the number of paramedics, the number of ambulances, fire stations, where they're positioned, public education about recognizing cardiac symptoms. And the last third of this process is a well-oiled machine. We know that the cath lab is doing this as quickly as possible and does as many things as they can to optimize the treatment pathway. So that leaves us with playing with the middle third. Now, traditionally, we would have, that is different than it looked on my computer. You would have scene time, transport time, then the EKG would be done in the emergency department, and then it would get activated. But the modern take would be to do the EKG on scene, activate from the scene, and then transport the patient to the ED. Now, the question is, how do we diagnose from the scene and who should be making that diagnosis? And that's a question of human versus machine. Now, on the human side, we can have paramedics do it, but that requires a potentially significant training investment, which there's an associated cost with. There's also an opportunity cost if you're spending time teaching on STEMI versus other things that they need to be training on, particularly if it's a fire-based service and they need to be doing, hazmat and other stuff. We could transmit it for a physician to look at, whether that's an emergency physician or a cardiologist, but there's cost in putting together the infrastructure for that, the equipment, the software, for getting it to the physician, as well as the physician time, increased interruptions in their workflow. And like I said, the downsides to both of these approaches are sort of the high cost, whether that's the training investment or the actual monetary cost of having a system for transmitting this stuff. Now, on the machine side, the main downside is the accuracy. These algorithms have a wide range of accuracy from pretty good to but the upside is that they are free 99, baby. It is included in the equipment you're already purchasing. It costs nothing to use it. Now, the machines have an ace up their sleeve, and that is machine learning. There are algorithms that are being developed today. I'm beta testing one for clinical use that are astonishingly accurate and can diagnose very subtle and very early MI with far greater accuracy than the vast majority of physicians. So this is what's coming in the pipeline, and eventually we'll see these machine learning, these better algorithms installed in the hardware that we're using. But there are a number of regulatory and other hoops to jump through to get that onto our current devices. For example, the LifePak 15 that you buy today has the exact same version of the exact same software for EKG interpretation as when it first came out over 10 years ago, despite the fact that there are newer versions of that same software available. And having talked with the company, it's mostly a regulatory issue, and working with the not the DEA, sorry, I've been watching Narcos, with the FDA, to expedite that process. So in this context, how do we improve care for our patients? I think it starts with getting the EKG, when we get it, and how we get it. So you can see here's a pre-hospital EKG showing an obvious inferior MI. Now, this EKG acquired just 4 minutes later shows resolution of the ST segment elevation, and presumably the patient would be chest pain free. Now, if you're like me, you're wondering, possibly as a recovering paramedic, how many times have I given the nitro and then gotten the 12 lead? How many times have I missed this? So how often does this happen? And the answer is way more often than you would hope. So in this study, relatively small, slightly less than 100 patients, the ST segment resolved in between a third and most of the time. It's a very wide confidence interval because of the small sample size, but at least a third of the time, which is a lot that you could easily miss. Now, patients that had ST segment resolution of their ST elevation, their lesions were just as severe. They had the same level of stenosis, the same TIMI flow, but as you would expect, their treatment was significantly delayed. And that was to the tune of a 20% absolute reduction in door-to-balloon time that was successfully done in less than 90 minutes, which I don't see Christy here, but I think I don't know where Christy is, but I can probably see her like starting to seize from that kind of knock and the metrics. Yeah. So this is my subtle way of trying to say that we must go faster. So timing is everything. The EKG needs to be done with the first subtle vital signs, and it needs to be done before giving any vasoactive medications like nitroglycerin. But I don't just want faster EKGs, I want more EKGs. So in this study, they had paramedics get an EKG, 3 EKGs for every patient, 1 on scene at the patient bedside, 1 as they were starting to initiate transport, patients loaded up or pulling away from the curb at their home, and 1 like as we're backing into the ED. Now, they caught about 85% of STEMIs on the first EKG, about 94% of STEMIs in the second EKG, and 100% on the third EKG. So I also think that we need to be treating the 12 lead as another vital sign that needs to be continually reassessed. So we can talk about the pre-hospital treatment. As an EMS fellow, I believe I am contractually obligated to point out the state protocol for treatment of this. There's nothing surprising here. It's nitro, aspirin, fentanyl as needed at the ALS level. There are 2 important flags that the state protocol points out. The most important being that we're getting the patient to the appropriate facility, and there is a designated point of entry plan for that, dictating when a patient goes where. And they've also, of course, mentioned avoiding hyperoxia, that our goal is to have normal O2 sats. I will also mention for the EMS people in the room that this is a great time to get your patient attached to your defibrillator. Hopefully you have upgraded from the LifePak 1 and you're no longer hand cranking to shock, but these STEMI patients have a nasty habit of potentially having ventricular arrhythmias. And so it's best if they're patched up ahead of time and you're not flustering. Now, the sickest of the sick may also develop shock. Now, you have to use your brain a little bit. And was the shock caused by the nitro I gave them, in which case it's appropriate to give them fluids, or are they in shock and it also looks like they're having a CHF exacerbation, in which case this is cardiogenic shock and what they need is pressors. So some paramedic services actually do carry Levophed and have IV pumps for initiating pressors, and this would be the appropriate time to do that and withhold fluids if you think it's cardiogenic shock rather than I gave them nitro and dumped their pressure. I will also mention the dogma around right-sided MI and inferior MI with giving nitrates and dumping the pressure. There are a number of pre-hospital studies that have been done at this point that have debunked that, showing that it's not the location of infarct, but ultimately the size of the infarct that predicts whether the patient's going to have a significant drop in their pressure with nitroglycerin. So this is the state point of entry plan for suspected STEMI or ACS cases. It essentially comes down to 4 major things in the decision-making. Does the patient have contraindication to lytics? Are there severe CHF symptoms, i.e. suggesting cardiogenic shock? Or are they hypotensive, again, suggesting cardiogenic shock, in which case they're going to go to a PCI center. If they don't have those things, but the difference between the closest facility and the PCI center is less than 30 minutes, then they're going to go straight to the PCI center. Now, if you are at all like when I was a paramedic, you're thinking, I'm supposed to know the contraindications for lytics? And unfortunately, when you go back to the protocol, the answer is yes. Even at the BLS level, EMTs are supposed to be screening patients for eligibility for fibrinolytics in order to determine the closest appropriate facility based off that last point of entry plan that I showed you. And if you go further down the protocol, it actually shows you that. Now, I'm not going to go through this, but essentially it comes down to, brain stuff. Have you had bleeding in your brain? Do you have an aneurysm? Do you have cancer in the brain? Or is there anything to suspect that this is an aortic dissection? Because giving lytics to an aortic dissection is poor form. So other conditions for pre-notification, stroke, we've been pushing this a lot, but unfortunately it's led to monstrosities like stroke ambulances that have CAT scanners in them, which have not been shown to improve patient outcomes and have not been shown to improve even the most basic metric of door to needle time. Sepsis, again, it shows increased compliance with the CMS measures, but that has not been shown to improve any patient-oriented outcomes, but it does give administrators all the tinglies because of how good their dashboards look. Trauma, another one. With the notification, we certainly like to know, but we don't know that it actually improves outcomes. Because knowing I think trauma patients are heterogeneous enough that how much time we have to get set up doesn't necessarily change things for how the patient's going to do, other than getting them to the right center that has things like mass transfusion surgeon available. Now, cardiac arrest, I will make a carve out here, and that is because of ECMO and the promise of eCPR for these patients, where we obviously need lead time to get this resource set up and ready to get the patient on pump. Now, most of these patients have deteriorated into a refractory VFib because of a MI or a STEMI, which brings us full circle and for me to wrap up. So I want faster EKGs, I want more EKGs, I want earlier pre-notification, and I want us to anticipate that the patient could arrest or otherwise deteriorate. I'm told that I'm supposed to have references, and that is all I have. Thank you.